muscle tissues are actually contracting now. So one different thing with the cardiac muscle cells is that they have automaticity, so they can automatically contract without a neuron. So what you're seeing here are cardiac muscle cells just on a plate. They're not part of a heart, they're just growing in a plate. You can take cardiac muscle cells out of a heart, put them on a plate, allow them to replicate, and they'll contract, which is awesome.
So without a neuron.
No neuron. Yep, and we'll talk about how that works. So they are still going to be controlled by a neuron because this does not, this doesn't beat to the correct beat that it needs to. But if you didn't have a neuron, your heart could still beat. So you have this network of beating cells, and it's not every cardiac cell. There's a certain subset of them that are called pacemaker cells, but they can signal to the rest of the heart cells to contract. And these are found in the SA node. So here's where that SA node is. And that makes sense, right? Because we want the atrium to contract before the ventricles. So we're getting our signal from this SA node. Those pacemaker cells contract, and then through those intercalated discs can signal the rest of the cells to contract.
Yep. Would you like us to know the neural pathway?
Mm-hmm. Yep, and I would suggest trying to overlay the neural pathway, and we'll see it step by step, which will help overlay the neural pathway with the cardiac cycle.
So you said that the neurons just help to sequence the contraction?
Right, so they're kind of modifying it. And we'll talk about what neurons are doing in a minute. So then the order here, we've got the SA nodes. These are the internodal pathways to the AV node, down the AV bundle, which goes through that interventricular septum. And then these branch into Purkinje fibers. And then these Purkinje fibers are what are going to be responsible for the ventricles contracting. And we saw Purkinje cells. Do you guys remember where we saw Purkinje cells? No, they're in the brain, they're in the cerebellum. And that's not related as far as structure goes. It was just the same guy named Purkinje that discovered both of them. So pretty important guy for physiology. Okay. So here it is step by step. So what you're seeing in purple is kind of the electrical signal and how it spreads throughout the heart. So we start at the SA node. Those pacemaker cells, they drift towards threshold, and I'll show you a picture of that in a second. These signal the surrounding cells to contract. That spreads down the atrium. And again, this is happening in both atria at the same time. That spreads down the atria, then down the bundle branches. There's a 100 millisecond delay, and that allows the atrium to contract, and then the ventricle to contract. So you don't want them to contract at the same time. You want the atrium to be completely done contracting by the time the ventricle contracts. Electrical signal spreads down that interventricular septum through those bundle branches, and then radiates out in those Purkinje fibers. They're all embedded in the ventricles. Then the ventricles contract, and now we're about 225 milliseconds. So then think about how that is going to relate to the pathway of blood and that cardiac cycle. So here's where you're getting the atria contracting, and here's where you're getting the ventricles contracting. Yep. You want to stay with the time reference? No, just the order. Alright, so an electrocardiogram is going to be able to tell us what the electrical signals of the heart are doing. So one kind of misconception is when you're looking at this, you're looking at the pathway of the blood or the heart's beating, but you're actually looking at the electrical signals of the heart. And that's why you're able to pick it up with these electrodes, is because it's an electrical signal that's passing through the heart. It obviously correlates with the heart beating, right? Because that electrical signal is causing the muscles to contract. But what you're actually assessing is the electricity running through the heart. So then it goes in alphabetical order: P, Q, R, S, and then we call this whole thing the QRS complex. And then the space between P and R is the PR interval, so the space between Q and T. Right, so what's happening in the heart during each of these steps? The P wave is showing atrial depolarization. So the cells of the atrium are depolarizing, and then that's going to cause atrial contraction. So just like our skeletal muscle depolarization. Okay? So then the impulse gets delayed at the AV node to allow the atrium to relax before the ventricles contract. The QRS complex is the ventricles depolarizing. When that's done, there's an interval between the T, and then the ventricular repolarization causes a change in the electrical signal as well. And then when it's repolarized, you go back to flat. So both depolarization and repolarization are going to cause these blips.
Yep. Where is repolarization of the atria?
So it's actually happening during the QRS complex. It kind of gets obscured by the QRS complex electrical signals. So I'm going to want you to be able to tell me what's going on in a typical electrocardiogram. You're not going to need to be able to diagnose electrocardiograms, just because it takes a lot of practice, and nobody's actually looks exactly like this. Everybody's got some variation in their electrocardiogram, and it takes a lot of practice to learn what's just normal variation and what's actually deadly issues. Okay, so skeletal muscle, when we put it into the context of cardiac muscle, actually has a very sharp refractory period and absolute refractory period. So skeletal muscles contract really fast and then relax really fast and have a relatively short refractory period. So you can contract and then contract again really quickly. Opposed to cardiac muscle cells, which have a more gradual contraction and a much longer absolute refractory period. So the reason for the prolonged contraction is because the calcium ions continue to enter the cell for an extended period of time rather than a quick open and close like in skeletal muscle. And then they have a much longer absolute refractory period. So why is it important for cardiac muscles to have a long absolute refractory period? You want to have time for the blood to fill the spaces. And you absolutely want to max out the speed at which your heart can contract, right? If it's contracting too fast, you don't have time for the blood to go in. You don't want the atrium and ventricles contracting at the same time, because again, blood would just shoot out of every vessel then. So that helps maintain the steps of the heart and make sure you don't have a heart attack. Make sure your heart doesn't seize up. So then what's going on at each of these steps? You have rapid depolarization, just the same as skeletal muscle tissues because of those voltage-gated sodium channels. The contraction is extended longer because there's slower voltage gated calcium channels. So remember that is what that calcium is allowing those cross bridges to form. So calcium gets let out slower for a longer period of time. So it's not like there's a big rush of calcium, all the cross bridges form, and then we're done. It's kind of let out slowly. And then the cell starts to repolarize. Those calcium-gated channels close, or those voltage-gated calcium channels close, and then slower potassium channels open, so you have a slower repolarization than you would for the skeletal muscle cell. So depolarization is fast, repolarization is slow. So then those pacemaker cells, remember that we find at the SA node that contract without a neuron being involved. They have a mind of their own. They have what's called pacemaker potential. They gradually drift towards threshold without any excitatory signal, without any neuron intervention. So they just let in sodium and eventually contract on their own. But if they weren't regulated, the SA node would fire about 80 to 100 beats per minute. So we need neural and hormonal control. If we didn't have neural and hormonal control, we also wouldn't be able to adjust our heart rate based on changing conditions, right? So if the pacemaker cells were just in charge of things all on their own, our heart rate would always be the same. So the neural and hormonal controls not only adjust this base heart rate, they're also going to allow it to adjust. So we can adjust heart rate, either making it faster or slower. So our normal resting heart rate, these pacemaker cells drift towards threshold by just letting in sodium. So they'll drift towards threshold, and threshold is different in cardiac cells. It's around -40 instead of -60. But they drift towards threshold here. As soon as they hit it, they fire. They repolarize, go back to resting, but then they just start to drift again. So then these are the pacemaker cells without any regulation. For the parasympathetic response, acetylcholine is going to open potassium channels on those cardiac cells. So potassium, is it going to go into the cell or out of the cell? Okay, think about it for a second.
Yeah, say that one more time.
If we open potassium channels, are they going to go into the cell, or the potassium is going to go into the cell or out of the cell? All right, here's our cell. What pump is going to control where potassium is? Sodium potassium pump. Sodium potassium pump is going to pump what out? Sodium, how many? And then, so overall, are we going to have high potassium inside or outside of the cell? Inside. So then if we open channels, which direction is it going to go? Out. Okay. And remember, potassium is positive charge, so what's that going to do to the charge inside the cell? More negative. Okay? So what do we call that when we make the charge in the cell more negative? Hyperpolarization. acetylcholine from the parasympathetic response is going to hyperpolarize the cells, which means it takes longer for them to drift to threshold. It takes more sodiums coming in for them to hit threshold and contract. So what does that do to heart rate? Slows down heart rate. So you get fewer contractions per minute. So sympathetic, think fight or flight. We know we're going to get more contractions per minute. For this, norepinephrine is going to bind beta-1 receptors. This is going to open our ion channels, and what ion channel would it most likely be? Sodium. So now we are depolarized. It takes less drifting to get to threshold, so it happens more often, and will increase our heart rate. So these beta receptors are going to be a major target for hypertension drugs, right? Because if you're preventing the heart from contracting more, you can do that by preventing norepinephrine from binding these. Then our normal range of resting heart rate is about 60 to 100. This is obviously going to differ by different people. Some people's resting is 100 and some people's resting is 60 and then shifted. But anything out of this normal range below that is bradycardia, and anything above that is tachycardia. So here are the neurons that are going to control that sympathetic and parasympathetic response. So first of all, it's going to be the medulla oblongata that controls heart rate, mostly. We have a cardioacceleratory center and a cardioinhibitory center. So the acceleratory center is going to be the sympathetic response. Makes sense. Want to speed up our heart rate. Inhibitory center would be the parasympathetic response. And then there's branches and ganglion and things. The most important part is going to be the cardiac nerve is going to innervate atrial and ventricular myocardium as a part of the sympathetic response. Okay.
Where did you say, like the inhibitory and what did you say?
There are centers in the medulla oblongata. There's the cardioacceleratory center. And these are just going to be areas where those neurons are found within the medulla oblongata, and a cardioinhibitory center, parasympathetic response. Okay. So sympathetic response, cardiac nerve. Parasympathetic response, vagus. So they both innervate slightly different parts of the heart. So the parasympathetic response is going to innervate the SA node because those pacemaker cells go too fast. So this is going to modulate those pacemaker cells and slow them down a little bit. It also innervates the AV node and the atrial musculature. So then it can slow the cells down at various stages. We get into cardiac output, unless there's any questions about the individual cells. Yeah.
One way to about the medulla oblongata and cardioacceleratory center is the area where the neurons are found.
So the cardioacceleratory center is a specific spot in the medulla oblongata where these neurons originate. All right, so cardiac output is going to be heart rate times stroke volume. And we'll talk about how we can calculate stroke volume. But cardiac output is just going to be the amount of blood that's coming out of your heart. And we usually represent it in milliliters per minute or liters per minute. Okay? So if a person had a heart rate of 90 beats per minute and a stroke volume of 80 mils per minute, take about 30 seconds, calculate that. Okay, what's their cardiac output going to be? You're a lot of different.
7,200.
72 is going to be 8 times 9. So 7,200. Yep, 7,200 mils per minute. So how many liters per minute would that be? 11.2 liters per minute.
We have to do that on the test.
Yes. But you can write it out, and it's not basic multiplication. You should be able to know. You should know how to tell. You can be able to convert mils to liters. But that's it. We're not going to have like nanograms or anything involved. Just those two. Grams per minute. Grams of dry blood. Alright. So our cardiac output can vary a lot. So even though our heart rate stays within a pretty finite range, we can vary our cardiac output. These are liters per minute now, not mils per minute. So resting is going to be around 7. Below about 3 is going to be heart failure. But then your cardiac output for a normal average person could go up to about 30 liters per minute. If you imagine like a liter of soda, what that looks like. Now think about 30 and think about that in a minute. That's how much blood is moving through your heart in a minute. And then when we talk about endurance athletes that are highly trained, they can make it up to like 40 liters. So heart rate plays into that, and we all know how to measure heart rate. It's pretty straightforward. But the other part is stroke volume. How much blood is in your heart and how much blood is leaving your heart. And there's a few different factors that control stroke volume. So this picture is showing us kind of two different representations. One looks like the heart and one looks like a pump. Whatever one works for you to understand. You're not going to need to tell me what is happening in this pump. But look at whatever part makes sense to you. But during the ventricular diastole, the blood is passively filling. And then the end diastolic volume is at the end of diastole, in the ventricles, how much blood is in there. So then the ventricles contract. And remember I said not all the blood is going to move out. That's going to be the end systolic volume. So end diastolic is going to be how much blood is in there at max volume. And then the end systolic is going to be the min volume. How much is left over after we pushed as much as we can out. Okay, so some blood remains in the ventricle, that's the end systolic volume. So then really what matters is how much comes out of the heart and we can use for our tissues, right? So then the stroke volume is how much we started with in this diastolic volume minus how much we left, minus end systolic volume. So how much actually leaves the heart. So then there's a lot of things that are going to change what the stroke volume is. One is just how much blood goes into the heart to begin with. And so we call that venous return. So how much blood from our venous system is actually making it into the heart. So some factors that control that is how much blood you have, period. If you have more blood is going to move into the heart. But then also remember your muscles, your skeletal muscles are going to control blood leaving that venous system. So this is one really quick and simple way you can increase your cardiac output while you're exercising, because your muscles are moving and it's pushing blood out of your venous system into your heart. So less blood in the venous system, more blood in the heart. And then that's going to relate into blood flow as well. So then your end-diastolic volume is going to be influenced by your venous return, so how much blood comes in, but then also your filling time. So if your heart is contracting too fast to fully fill, you're going to actually drop your end-diastolic volume. Okay? So your heart needs to be relaxing for long enough to be fully filled with blood. So then other factors that are going to affect stroke volume, preload, which is the amount of stretching. And just like our skeletal muscles, there's an optimal sarcomere length for strength of contraction. So if the heart is not full, your sarcomeres are going to be very short. There's not a lot of contraction that can happen. If it's stretched out because you have a lot of blood, there's a bigger contraction that can happen. So that's your preload. How much myocardial stretching do you have based on that end-diastolic volume? So the more blood you have in your heart at this end-diastolic volume, the harder it's able to contract and push out. So then other things that control the ability of your heart to contract are going to be the things we just talked about, the sympathetic response, hormones, and then any drugs that you are taking, so like those beta blockers. And then the end-systolic volume is influenced by the contractility, so the contractibility, the ability to contract, and the afterload. The afterload is the tension in the contracting ventricle needed to open the semilunar valve and eject the blood. So how much pressure is being produced by that ventricle? A strong ventricle contraction is going to push out the most amount of blood and leave the least amount on the table. So leave the smallest end-systolic volume. So preload and afterload tend to be a hard concept for students. Our students are helpful sometimes. Okay, so preload is going to be the amount of blood coming in, you get the stretching, and then if you get enough stretching, you can have a stronger contraction. Afterload is the resistance that the ventricle meets when it's contracting. So it's pushing hard, and the harder it pushes, the more the afterload, the harder the heart has to contract to get over it. So then some drugs that are going to decrease the contractibility, like we said, beta blockers are going to block the sympathetic response. And then keep your heart from contracting as frequently. And there's also calcium channel blockers that are going to prevent that calcium from going out the sarcoplasmic reticulum. So even if you have signals telling your heart to contract, it's not going to contract without calcium to release that inhibition of troponin and tropomyosin. A lot of this is pretty intuitive. We have things that affect our heart rate and things that affect our stroke volume. So these are the heart rate things, and you could probably just rattle these off just from being a person. Sympathetic response is going to increase your heart rate. And what neurotransmitter is most important there? Acetylcholine is going to be for parasympathetic. Norepinephrine for sympathetic. Yep. Body temperature and exercise. So your heart rate is going to increase when you're warmer and lowers when you're colder. And then it's going to increase when you're exercising. And then hormones involved in that. Epinephrine, norepinephrine, thyroxine Where's that from? What organ? Thyroid. Yep. So remember, the thyroid is going to play a lot of roles in your metabolic rate. So if you have hyperthyroidism, you're usually low body weight, extra activity, agitated all the time. You're in high metabolism mode, so it would be high heart rate. You have hypothyroidism, not enough thyroid hormones, kind of sluggish, low energy, low heart rate. Alright, so here are the things that affect stroke volume. So remember that stroke volume is going to be the end diastolic volume, the amount of blood that comes into the heart, minus the end systolic volume, the amount that's left over after it contracts. So then we can affect either of these to affect the stroke volume. And remember, the stroke volume times the heart rate is going to give us the cardiac output, which is really what we care about. How much blood is actually making it to our tissues per minute. So remember, exercise, just contracting those muscles is going to increase your venous return. And then the more blood in the heart, the higher the end diastolic volume. So you push blood out of the venous system into the heart, so you have a higher end diastolic volume. If you have a drop in blood volume, that's going to do what to your end diastolic volume? Decrease it. You have less blood, so less blood's going to end up going to your heart. Or if you have changes in flow patterns, can change your venous return. So if you're in your sympathetic versus parasympathetic response, or you're really, really cold and the blood is diverting away from your extremities, things like that can affect your venous return. Okay, the end diastolic volume is going to be what determines the stretching in those ventricles, and that preload is going to influence how efficient the ventricles can contract. Okay. So the end diastolic volume is going to directly relate to the end systolic volume. So if you don't have enough blood coming in, the preload is going to be small, your sarcomeres are going to be short, you can't forcefully contract. And that's going to leave more blood in the heart. Okay. So some things that are going to affect that end systolic volume as well is just how efficiently those heart cells are contracting. So if you have things that are decreasing the amount of contraction, then you're going to have more blood left in the heart after that contraction. Okay, so these can either be nervous system things or hormone things. And then vasodilation and vasoconstriction can affect the afterload. So vasodilation is going to decrease the afterload because there's less back pressure from the pulmonary trunk and the aorta that needs to be overcome by the ventricles. Okay. So vasoconstriction makes those vessels smaller, it's harder to push against them, and so you're going to leave more blood in the heart. Okay. So it's kind of like backlogging the heart, so it's not able to push as much blood out. Does that kind of make sense? So go ahead and talk with the people around you and answer these.
Increased heart rate would increase your cardio output. Cardio output equals stroke volume times heart rate, right?
Yep.
Increase venous return. So more blood is coming into the heart. I think that
That would increase. Yeah.
yeah, because stroke volume would increase. Increase and systolic volume. I always forget that. So there's systolic, so diastolic would mean more blood is pumped, right?
Yeah.
Systolic is what's left.
I don't know. Double check that.
And systolic. And diastolic is when venous return increases, stroke volume increases. And then increases and diastolic volume.
Okay. Okay.
So I think that's
Yeah. Just double checking.
the afterload. Increase in afterload decreases pumping efficiency.
Study efficiency.
So that would decrease it, right?
Yeah. It would decrease it if it's, the efficiency is being lowered.
And then increase parasympathetic stimulation. Fetal blood flow would differ from adult blood flow.
Lower rates. I don't know. Just not much of a body to pump blood around, but I don't know. Then the heart's probably not as big.
Yeah.
So maybe I don't know what would be.
These are just kind of
Oh, fetal, yeah. I don't really know. That's a good question.
And the hemoglobin differ from adult. Yeah, I don't know.
Yeah, it's a good question too.
Maybe some.
There's a number of oxygens it can carry or something. Or...
When are you? So you're going home and then to when do you
Right after movement.
And when do you fly out to
Wednesday morning.
Nice, so you'll be at home for a little bit.
Yeah, it'll be good. I lowered the plane ticket somewhat, so it'll be nice. Except for driving. But
How far is it from you?
it's only 8 hours.
It's not horrible, but definitely long.
Yeah, boring. Central Wyoming is nothing to write home about.
Me too.
I don't know what the ones are
Yeah.
louder. I didn't drive there.
Yeah.
And we play it in class.
Uh-huh.
America games, whatever. We'll try to come over.
Alright, increasing heart rate will increase or decrease cardiac output. Increase. Increase venous return. Increase. Increase in diastolic volume. Increase. So, in diastolic volume, stroke volume is going to be in diastolic volume minus in systolic volume. So the bigger the in diastolic volume, the higher the stroke volume, and the higher the cardiac output. Yep. All right, increased afterload. Ooh, mixed bag. All right, so afterload is going to be kind of like the back pressure of the vessels pushing back. The higher the afterload, the lower the pumping efficiency, and the higher the in-systolic volume. So the higher the in-systolic volume, the lower the stroke volume, so the lower the cardiac decrease. Yep. That's one that's tricky. Okay. Increase parasympathetic stimulation. Decrease. And even if you didn't think through the whole process of hormones, rest and digest, lower heart rate, right? Okay. So So how might the fetal blood flow differ from the adult blood flow? So do babies' hearts beat in the womb?
Yes.
Yep. So that's one of the first things you look for on the ultrasound, baby's heart's beating. So the heart is beating, but what is not? The lungs are not working, right? Because they're living in a sack of fluid. Okay? So how might the flow through the heart differ? Right, bypass that pulmonary circuit, because where does baby get their oxygen? Mom, through the placenta and the umbilical cord. Mm-hmm.
So is that where that little oval hole comes in?
Yep, so that's bypassing. Yep. So instead it's going through that hole instead of through the whole pulmonary circuit. And we'll see a picture of that.
Is that the reason why their heart rate is?
Mm-hmm. Yep. So it's unregulated heart rate basically. And they can have a lot of variation in their heart rate, which I wish I had known. Because when I got my first, well not my first, maybe like my third or fourth ultrasound, they saw an irregularity in my baby's heartbeat. And then the ultrasound technician isn't allowed to diagnose or tell you anything. But she kept going back to the heart and taking more and more videos. And then my doctor called me in for an appointment the next day, and I'm like, oh my god, something's terrible. And then did a 3D ultrasound, and it's fine, and she's obviously fine. But that was like the worst weekend of my life. I was in the research lab doing radiation work and stuff, and I'm like, gave my baby a heartbeat. But because babies and normal people have some irregular heartbeats every day. So if you have a grandparent that's like, oh, I'm testing my heart rate every 30 seconds because I had a heart attack and now I need to watch for it, or you've got a Fitbit or whatever, there's variation in your heart rate and it's okay. And actually freaking out about it is much more destructive than having an irregular beat every once in a while. Okay? So how might fetal hemoglobin differ from adult? Not necessarily more oxygen. So it just has a higher affinity for oxygen. This was just kind of a prediction thing. I hadn't talked about this yet. So if you didn't. So fetal hemoglobin has a higher affinity for oxygen than adult hemoglobin. And that's why babies can basically snatch oxygens off of mom's hemoglobin to then deliver it to their own bodies. And it's one of the many reasons why pregnant ladies are tired all the time. Alright, so there's our fetal blood flow. So the placenta kind of has these cells that are all pooled together, and then we've got the oxygenated blood coming in, and this is another place that breaks the arteries and veins oxygenated, deoxygenated rule. So oxygenated blood comes in through a vein through the umbilical cord, and then runs up through the liver, and then ports into the inferior vein cave. Okay. So then baby pretty much just has oxygenated blood running into their whole heart. And then they bypass the pulmonary circuit through the foramen ovale. So instead of going through the pulmonary circuit, just goes straight back into the heart, from the right to the left atrium. And then there's a port between the pulmonary trunk and the aorta that allows passing of blood between those two. So then the heart beats, and it delivers oxygen to all the baby's tissues. So it's important that baby's heart is beating. Even though mom's oxygen is coming in, baby's heart is what brings it to all the tissues. And then the oxygenated blood is coming up through the venous system, but that's going to have bypasses that go back into the umbilical cord, because baby can't breathe out that CO2. So that deoxygenated blood's got to go back through the umbilical cord, through the umbilical arteries, to be recycled back out through mom's respiratory system. So heart rate and respiratory rate tend to increase when you're pregnant. So then remember, I said these ports are supposed to close when the baby has their first breath. And that's like the longest second of your whole life, is why you're waiting for that first breath to happen. But when that first breath happens, those portals should flap closed, both the foramen ovale and the ductus arteriosus. That becomes just a ligament that connects those two. There shouldn't be blood passing through it. And then the pulmonary circuit comes alive. So these are not to memorize, but these would be a way to apply your knowledge of the structures of the heart. So be able to think through them and understand what physiological issues you would have if you had these heart defects. Okay? So heart defects are going to be our country's #1 birth defect. So almost 1 in 100 babies is born with a heart. So that interventricular septum, what does it normally do? Yep, so separates the ventricles. If you don't have a full ventricular septum, the more powerful left ventricle is going to push oxygenated blood into the right ventricle. Okay? And anytime you get mixing of oxygenated and deoxygenated blood, you do normally, but anytime you get more than normal, then the heart has to beat harder and more frequently to deliver the same amount of oxygen that it normally does. So same thing here, if you have an open or patent foramen ovale or an open ductus arteriosus, you have mixing of oxygenated and deoxygenated blood, and the heart has to work harder to get enough blood into the system and circuit. And this is often diagnosed once the baby is born if they look blue. Now we're starting to get more serious. Like we need to have surgery in the womb or right after the baby is born. So the tetralogy is going to be 4 things that are wrong with the heart. 1, pulmonary trunk is abnormally narrow. 2, interventricular septum is incomplete. So same thing as this guy going over here. 3, the aorta originates from where the interventricular septum usually ends. The aorta is in the wrong spot. And 4, the right ventricle is enlarged and thickened because it has an increased workload. So it's compensating for blood being pushed from the left ventricle into it. So you can also have an atrioventricular septal defect, so the atria and the ventricles are incompletely separated rather than just the ventricles up here. And this is very common in Down syndrome children. This one is bizarre. Your aorta and pulmonary artery are split. And this obviously has to be repaired because you don't want your deoxygenated blood going to the rest of the body through here, and your oxygenated blood going back into the pulmonary circuit. Okay? Questions about that? So we've talked about the regulation that can happen directly at the heart with cardiac output, but the rest of the body, the blood in the rest of the body can be regulated as well. And that'll regulate things like venous return. So then the reason that the heart has to beat is because there's peripheral resistance. So the cardiovascular system provides resistance to the blood. So the heart has to beat hard enough that the blood can move through the entire cardiovascular system. So peripheral resistance is going to depend on vascular resistance, just the friction of the blood moving through the vessels. Viscosity, so how thick the blood is. So the thicker the blood, the harder it is to pump, right? And then the turbulence. So any non-smooth vessels are going to cause kind of backflow and make it harder to pump the blood. So resistance is going to be affected by vessel length. So the longer the vessel, the harder it is to push the blood through it, right? So if you think of this like blowing a liquid through a straw, if you had a straw that was 3 feet long, it's harder to blow liquid through it than a straw that's this long. And you don't need to know these exact numbers, they're just kind of the ratio to each other. And then vessel diameter is going to affect resistance as well. So it's going to be easier to blow liquid out of a straw that's this size versus a little cocktail straw that's teeny. So then the diameter is going to be more important than the length when determining resistance. And again, you don't need to know this math. This is the cardiac output math. All right, so viscosity is going to be the thickness. So blood is literally thicker than water, and that's because it's got a lot of proteins and solutes and cells and all sorts of stuff in it. But it shouldn't be thicker than maple syrup. So it's going to be less viscous than, say, molasses or more viscous than that. So what do you think is going to affect the viscosity of your blood? Hydration is going to be the biggest factor that determines the viscosity of your blood. So the more water you drink, the less viscous your blood is. And then when you go to donate blood, it takes 5 minutes instead of a half an hour. All right, so turbulence is going to be anything that disrupts the flow of blood. So one major thing that can affect the flow is going to be any plaque deposits. So even if that plaque isn't fully closing off the vessel, it's still going to be affecting your heart because it's slowing down the flow and therefore increasing the resistance. So then your heart has to be harder to overcome the resistance in the vessels. There's some turbulence that's built in. So there's resistance between the aorta and the ventricles and the aorta and pulmonary trunks, just because there's kind of a jog between where they're attached. That's good, it slows down the blood a little bit. But any kind of non-built-in turbulence starts to increase resistance. All right, so then the blood flow is going to depend on the pressure and the resistance. So if you increase the pressure, what's that going to do to flow? Increase the blood flow. So the harder you're pushing it, the faster it's going to flow. And resistance, what's that going to do to the blood flow? Decrease. And remember, you can increase the resistance by messing with the viscosity or the turbulence. You wouldn't really mess with the vessel unless you're doing some extreme body modification where you have extra vessels. I don't know. So the total pressure is less important than the pressure gradient. So the pressure gradient is going to determine movement of liquid in and out of your vessels. So there's a difference in pressure between the beginning and the end of a vessel. And think about your vessels, they're always going from a big vessel to a teeny tiny vessel. So what do you think the largest gradient is between? What's our biggest vessel? Aorta. And then between that and what are the smallest vessels called? Capillaries. That's going to be the biggest pressure gradient. So then that gradient is going to be controlled by the cardiovascular center of the medulla, Same thing, the same area that controls the heart rate. So remember we talked about the cardioacceleratory and the cardioinhibitory center. Well, we haven't yet talked about the vasomotor center. So that guy can control the gradient in the vessels by contracting and dilating the blood vessels. And by doing that, it can alter the blood flow. And by altering the blood flow, you can alter the cardiac output because you can alter venous return. And by altering peripheral resistance, you can affect afterload. So how hard is it to push blood out of the heart? Alright, so this shows the vessel diameter, which we just talked about. So the biggest is the aorta. And then we go through the elastic arteries, muscular, arterioles, capillaries are the smallest, then venules, veins, and then the vena cava is the biggest vein. Now, if we compare that to the pressure in those vessels, though, the aorta is closest to the heart, it's going to be at the highest pressure. And then as we move away from the heart, we get lower and lower pressure. But why do we not go back up as the veins get bigger?
It's farthest away from like the pump.
So these are not only far away from the heart, it's just skeletal muscle that's controlling these, but that we're also going against gravity most of the time at this point. So then that plays into velocity. So the bigger the vessels, the lower the resistance. So it's easy to move through that big straw. And hard to move through the tiny straw. So then it speeds back up as it gets to the big vessels. But because we don't have that pressure of the heart, the vena cava is never going to have blood moving as fast as the aorta does. Alright, so then when we measure pressure, when we measure blood pressure, what we're measuring is the pressure in the arteries. And these tend to be big arteries, because can't really measure the small capillaries very well. And then we measure contracting pressure. When the heart is contracting, so that's the systolic, that's the upper dotted line here, and diastolic is the lower dotted line. Diastolic here, systolic here. So then that top number of blood pressure is going to be when your heart's contracting, what's the blood pressure? When it's relaxing, what's the blood pressure? And then you can use those to calculate the mean arterial pressure. Questions about that? So the next thing we're going to talk about is how liquid moves in and out of your vessels. And that's going to control your the amount of blood you have and the viscosity and all of that, as well as your level of hydration. So there's a lot of factors at play. They're going to control movement of liquid between your interstitial fluid and your blood vessels. And these are just going to be your capillaries, not all your blood. So remember way back to maybe like the second or third lecture, we had hydrostatic pressure and osmotic pressure. Those concepts are going to be really important for this section. So capillary hydrostatic pressure is the blood pressure. So the force with which the blood is moving into those capillary beds. So that's going to be affected by the amount of blood you have and just the pressure that the heart is pushing it with. So physical pressure is going to push liquid out of the capillaries. And we call that filtration because it's not a completely open door, right? There's space between those cells and only certain things can fit in that space. But if they can fit through that space, they're going to be pushed out because this is high pressure. So this out of those spaces between the cells, but not full cells. Okay? So that's what it looks like. Spaces between the cells of the capillaries. Pressure with which the blood's moving through those capillaries is blasting small things out of the vessels and into the interstitial fluid. Okay? So this is also going to be where our gas exchange is happening, right? So the tissues are going to give up CO2 and the hemoglobins are going to give up oxygens, but also things like glucose and hormones and all sorts of things are going to move out to the cells, and then things can move back in to the vessels. So, reminder, diffusion happens with or against the concentration gradient. Always with. And it's most efficient when distances are long or short.
Short.
And the gradient is steep or narrow. Steep. And the molecules are big or small.
Small.
Small. Okay, so there's a few places where diffusion can happen between the cells or through the pores of the fenestrated capillaries, channels within the cells, diffusion through the plasma membrane, or gaps in the cells and most sinusoids. If you don't remember what those fenestrated capillaries are, or those sinusoids are, go back to the beginning